Without further delay, I'd like to introduce the last student group. So it's Scott Bernaerts, Eric Demers, Jordan Miller, Jesse Shelton, Tristan Groef, and Emily Weston, and they'll be speaking about estimating pediatric weights by paramedic students. Give them a round.
Hello everybody, thank you for coming today. My name is Scott. I'm joined on stage by Jordan, Tristan, Jesse, Eric, and Emily. We'd like to talk to you today about our research question, can paramedic students accurately estimate pediatric weights? But first, a question for the audience, and please do feel free to voice an answer if one comes to you. How much would you say this adult polar bear weighs?
400 pounds.
I hear 400 pounds. 400, 1,000.
700. Enough to break ice.
Enough to break the ice. The answer that I was relieved to hear, to get this rolling a little bit smoother. Now, to give you the exact weight, I might have to consult with David Attenborough on that one. I'm not sure how much an adult polar bear does weigh, but I can tell you that it's enough to receive 0.5 milligrams of epinephrine injected IM for suspected anaphylaxis. I can tell that by eyeballing the adult polar bear. I'm not so sure about those two young cubs though. I might have to work at that a little bit harder to figure out what my dose would be. And therein lies the nature of our research. So I will be going over a quick introduction of our research. Eric will talk about the importance. We'll move to Emily to review our literature. Methodology will be discussed by Tristan. Jordan will talk about implications, and finally data by Jesse. So it's no secret that we have to rely on weight-based dosages in our practice as paramedics or as paramedic students. This is evident by looking at the basic life support or advanced life support patient care standards. There are many examples if you open up those documents you can find within our core directives. However, determining what those weights are to base your dosages could be a little tricky. It's agreed upon that perhaps the most accurate way to do this is to simply ask your patient. Ask him or her, how much do you weigh? The same can be said for pediatric patients. Sometimes the best thing is to ask the patient or to ask the patient's mother or father, how much does your child weigh? This is not always an option. Sometimes it's tricky based on levels of responsiveness, or perhaps there could be a language barrier that prevents you from doing this. In that case, we sometimes do have tools in the pre-hospital setting. You could use a Broslow tape or perhaps a popper tape. But these are tools that are not common to every service. Not every truck has these tools on board. Not every paramedic is familiar with these tools. So we move to some calculation-based estimations, and these are commonly done by estimating based on age. So maybe an age times 2 plus 10, or an age times 2 plus 8, even an age times 3 plus 7. These are all common examples of formula that our research team has found. But again, these do little to incorporate the relative size of patients and are more or less based on strictly just the age of the patient. So there must be a better way to do it, and we find ourselves as students, later in our careers as paramedics, having to sometimes rely on our visual estimation skills, and that is the importance that we would like to stress today. And I'll pass it over to Eric to further that point.
Thank you, Scott. So my name's Eric, and today I'll be asking you the question, why do we think it's important for paramedic students to accurately identify weights in pediatric patients? So one of the things that most of us here, if not there are some in the crowd already, is we're going to be paramedics on the road very soon, treating our patients with our symptom relief and other interventions that we can do. Many of these interventions come down to weight-based calculations for medications. One of those medications, such as dextrose, comes in a 10% solution and a 50% solution. And each one of these medications are given based on the patient's weight. So if you estimate a weight and you're off as much as 20 kilograms, then you could theoretically be overdosing your patient on something like dextrose and putting that patient in with the possibility of rebound hypoglycemia as well. Another thing we can look at is fluid overload in patients, especially when it comes down to pediatric patients. They don't have the ability to compensate as well as adults do. So the key point to get the right amount of medication or the right amount of fluid into this pediatric patient so that you're not causing any more harm. Another thing that I want to stress on is the research for pediatric patients and estimating weights. So far, it's only been conducted in Australia, so we're mirroring our research based off of them. So we want to bring it here to Canada and hopefully to other countries around the world. Hopefully, we'll get more research and there will be more results in terms of whether or not we can accurately identify weights in patients. Another thing too is just the education behind this as well. So we want to bring the attention that maybe there will be a need for change in education amongst paramedic programs across Canada or in other countries around the world. Finally, I want to talk about patient advocacy. As paramedics out on the road, our main goal is to be patient advocates. So one of those things comes down to do no harm. And basically what that means is to prevent harm to your patient by not overdosing, underdosing, and bringing the patient to the hospital with the best possible patient care provided by us as paramedics. So now I'll pass it over to Emily, who's going to talk to us about our literature review.
Thank you, Eric. So to start our project here, we went on to CINAHL Plus with full text and Medline databases, and we plugged in some words, including but not limited to pediatrics, children, weight, kilogram, pounds, pre-hospital, emergency, paramedics. So of those terms, once combined, we found a total of 150 results, and we narrowed it down to 5, simply for the fact that those were more focused on what we were looking for. So the first one that I'm going to talk about is Young and Kreutzer in 2016. So they simply decided to take 8 previous studies that looked at different ways to estimate weight. So they used an age-based formula, a length-based formula, and by simply asking the parents or guardians at the time. So they actually found that the most accurate method was to ask someone nearby related to the patient how much the person weighed. They found that the least accurate was the age-based. So the one that we are taught in class was actually the least accurate method. They stated that there are no methods currently available to us that are most accurate, and that there needs to be one created that is equipment-free, easy to use, and includes kids from all populations. So the next one that we used was done by Vilke all in 2001. So they took 20 medics working in San Diego County with an average of 6 years experience, and they were asked to go to 4 patients, real-life pediatric patients, calculate their weight based on estimation, simply by looking at the patient, and then administer the first dose of epi for a cardiac arrest as per their county protocol. So from that study, they found that less than half of the 20 medics were comfortable working pediatric calls, and only less than 75% felt comfortable estimating weights of those pediatrics. Of the 20 medics with the 4 patients, they found that 10% of the epinephrine doses that were calculated and administered were actually overdosed by a factor of 10. So 10 times the factor of the actual dose was given, which is obviously not very good. So third one there was done by Engelmeyer et al. In 2004. So they took to hospital ERs and found 396 medically stable patients. Now they used people over the age of 17, so they used adults. They used attending and resident physicians, paramedics and nurses, and as well as just asking the patient themselves how much they weighed. And of those 5 groups, the paramedics guessed the worst. So they found that the paramedics out of all 5 groups that are required to estimate weight actually estimated the worst of all of them. They found that 21.5% of the guesses of the paramedics were within 5% of the weight, which is not good as well. So the last 2 that I'm going to talk about were done by Williams et al. The first one in 2010. So these 2 were actually what we based our study off of, which Tristan will talk about in a little bit. But they took pictures of patients, varying ages, varying weights, and they did a slideshow, a PowerPoint slideshow. So they had 2 images of the patients up on a slideshow for 15 seconds, and their participants were asked to guess the weight of the patient and write it down. So like I said, that's kind of what we based ours off of. But they found from their study that of the 7 patients' pictures that were posted up on the slideshow, 16% of their participants were within 5% of the weight, and only 73.2% were within 20% of the weight. So for those of you that don't know, 20% weight difference can be quite a lot of weight added, which can affect a dose of medication quite significantly. So the last study was done by Williams with Boyle in 2015. So it was the same PowerPoint, but they found that of their nursing students and medic students, that the medical students actually did the worst again. So they concluded that most students underestimated the weights simply for the fact that they could not guess appropriately. So I'm going to turn it over to Tristan, who's going to talk more about our methods.
Okay, so I'll be talking to you guys about the methodology that we used for our study. So I'm just going to briefly go over our population, our study design, the materials we used to conduct the actual study, and the procedure that we followed for both first and second year paramedic students. So for our population, we included first year and second year PCP students here at Fanshawe College. The participants ranged in females and males with a total of 67 students participating in our study. The only people who were excluded from our study were people who had prior knowledge of one or more of the pediatrics that we used in our PowerPoint, as some of them were professors and instructors. Children, so if they were in the lab before and somebody had used them before, they were excluded from our study. For our study design, we conducted a prospective observational study where we looked to see if first and second year students could accurately estimate pediatric weights through images via PowerPoint. So the pediatrics were not actually in the room. We took some pictures that I'll explain a little bit more with the actual procedure. So the materials that we used for the study were a Nikon D7200 camera with a tripod. So it was the same camera, same tripod taken for all the 10 photos that we used. The tripod was set at the same height and the same distance away for every picture, as well as the background. We try to keep it as consistent as possible with just a plain white wall. Just to add some ease for looking at a picture and trying to estimate weight, we added the BLS bag that we have here at Fanshawe College that we use in the lab, just because as a group we thought that everybody who would be participating in the study would have a good grasp of the size of it, so it was kind of a size reference we tried to put into the pictures so it wasn't as difficult to estimate. So this is one of the pictures that we had taken for the PowerPoint. We did not actually include this one in our study. PowerPoint, so this is just kind of something for you guys to look at. We also provided an answer sheet for them, the participants, to record their answers on. It had a spot for their estimated weight, whether it was in pounds or kilograms, a randomized identification number to keep it completely anonymous, as well as an area to select if they're PCP1 or PCP2 students, as well as male or female. So as for how we ran our presentation, we had all the participants in a classroom that acted as a closed environment, just so we'd have zero distractions for the participants to make their estimations of the PowerPoint. Before we started, we explained that they'd be shown an image of a pediatric with a frontal view and a lateral view, like you see up there, and that they would be given 15 seconds to think of their estimation and record it before moving on to the next. At this point, we also just wanted to kind of reiterate that this presentation wasn't meant to be a stressful experience for them. It was strictly just to see if they could identify weights of the pediatric patients, which is why we had it in a closed environment for all of our presentations. We also explained that the pediatric images would have a black bar across the eyes of the child in the image, just so that when the first picture came up, it didn't catch anybody off guard and distract them from their first answer, so we could keep all of the time periods consistent. After all the answer sheets were collected, after all the after all the answer sheets were collected by the collection team of myself and Jordan, we told the participants that if they wished to not actually participate in the study, they could leave before we started the presentation, but we just asked that once the presentation started, that they stay for the entire presentation. So with that, I'm going to pass it off to Jordan.
Good afternoon, everyone. I'd like to start by just asking everyone a couple questions. They're kind of inspired by the Price is Right game cliffhanger up behind me. The first is, who here feels that they could look at a pediatric patient and estimate their weight within 5 pounds the majority of the time? No one? Yeah, me neither. Okay. How about within 10 pounds? Okay, so we might be sending someone off a cliff. That's okay. So going into our study, we hypothesized that the first and second year paramedic students would both be unable to accurately estimate pediatric weights. In addition, we anticipated that the second years would not be able to perform at a higher level of competence compared to the first years. Previous research has shown that working paramedics have a tendency to overestimate pediatric weight, and so we thought we'd see a similar trend with the first and second years. And basically, if our results show that the students cannot estimate weights properly, we would just recommend that the students receive kind of further exposure to pediatric patients, whether it's in lab, out in placements. And we'd like to see new comprehensive tools be introduced so that medics and students can both use them in the future to help estimate. And I will now give it over to Jesse, who will go over our results.
Thank you, Jordan. So regarding our data, we use SPSS just to analyze our data for our 10 pediatric patients, which are referred to as subjects in our upcoming tables. Descriptive stats were determined to determine trends as well as comparison t-tests. Participants were given the options to estimate weight in either pounds or kilograms. All the tables today have been presented to you in kilograms. So of the 67 participants, we had a total of 38 first years and 29 second years. And of the 67 participants, 33 of them were females and 34 of them were males. So here in table 1 behind me, we have all 10 subjects, their actual weights, mean estimation, minimum and maximum estimation, and range of our 67 participants. Of our subjects, B and F were the most accurate within 0.02 kilograms. A, C, E, H, I, and J were all underestimated with most notably A and C under by more than 8 kilograms, and I and J by under more than 5 kilograms. Subjects D and G were overestimated, with notably G over by more than 4 kilograms. Here in Table 2, we have the percent estimate within actual weights. Overall, only 18.8% estimated were within 5%, 38.4% fell within 10%, and 62.4% fell within 20% of the actual weights. To give you perspective, of the 67 participants for each of the categories 5, 10, and 20, 12, 26, and 42 participants represent each of these categories of the participants. The most accurate subject was E, when looking at 5 and 20% estimation range, and subjects F and H were the least accurate when looking at 5 and 20% range of estimation. Here in Table 3 is our first t-test comparison when comparing first and second year estimation. Statistical significance was observed only in subject J with a p-value of less than 0.05. Overall, second year students were found on average to underestimate weights in 7 of the 10 subjects, whereas first years underestimated in 5 of the 10 subjects. The average weight estimation by second year students was lower than the average estimation by first year students in 8 of the 10 patients. Finally, here in Table 4, we are comparing the estimation between female and male estimation. The only statistical significance we found was J, again. P-value was below 0.05. Overall, females were found on average to underestimate weights in 5 of the 10 subjects, whereas males underestimated in 7 of the 10 subjects. The average weight estimation by male students was lower than that of female students in 8 of the 10 subjects. So to briefly conclude our findings, first and second year paramedic students cannot accurately estimate pediatric weights, nor were second year students any more accurate than first year students. One trend that we did observe though that was different was that we tend to underestimate as opposed to overestimating pediatric weights. That concludes our study. I would like to open up the floor to any questions now.
Thank you, Kate, PCP student, and I apologize if I missed this in your presentation, but of the pediatrics that you had photos of, were they kind of a wide range of ages and weights therefore, or were they kind of all around the same age? Like I'm kind of wondering, were they be worse or better at infant kind of age versus maybe, 10 or 12 year olds kind of thing?
So we actually did have a wide range. We had as young as 1-year-old to as old as, I believe, 16. So we did span the age of all pediatrics. Your question about whether they were better with younger ages versus older ages, I can't personally talk about. We didn't actually give our data analysis team the ages of the patients. We simply just gave them the weights. So I'm not sure if that's something that we actually did consider, but we have the data that we could go back and figure that out, yes. Does that answer your question?
Yeah, thanks, Emily.
Alberto, PCP student. Just wondering, compared to the, from your lit review, all the data that you found for that, were your results similar, or were we less accurate, more accurate than what you found previously?
Thank you for the question, Alberto. Generally, we found that the results that we got from our study, and keeping in mind that we closely mirrored a study done by an Australian research team led by Williams, our results did very closely mirror theirs. In fact, the second table that Jesse showed with the percent ranges. I believe 18.8% of the estimations made by our first year and second year students were within the 5% range. I can't recall the exact number that Williams and that research team got themselves, but it was very close to that. And our trends showed very similar to theirs as well. Thank you. Thanks.
Sorry guys, one more. Kate again. Just from talking with you guys previous to this study, I believe you maybe let people answer in pounds or kilograms depending on what they were most comfortable with, just because of the speed of the study. Did you find that people were more accurate or less accurate depending on whether they were answering in pounds or kilograms?
Thanks for the question, Kate. I'll answer this strictly because I was part of the analysis team with the data, so I got to see kind of the data in initial stages and see what estimations were coming through in pounds or kilograms. So of the 67 samples that we collected in estimations, 5 of them, so 5 students answered strictly in kilograms. 2 students chose to do a bit of a mixture. Some subjects, they answered in kilograms, some in pounds. And again, there's no penalty for that. We told our participants that they were free to choose whichever they would like. And as researchers, we would convert to a common system, and we used kilograms for that. So 5 students using kilograms, 2 students using a mixture, and the rest of our 67, so 60 students chose to use pounds exclusively. We did not take a look at whether or not estimating in kilograms versus pounds was any more or less accurate, but given that there was such a small sample of people that chose to use exclusively kilograms, it would be difficult to prove statistically that they would be any more or less accurate, considering there was only 5 people that did that. Thanks.
Hi guys, Trevor, PCP student. Just a quick question around the timing for the people. So they were given a period of like a shortened time exposure to the actual image to make their estimation. Do you feel that would have impacted, depending on, you know, they're looking at it, they're trying to write it down, trying to do the math in their head. Where did you come up with that number for time, and do you feel that that might have impacted people's ability to estimate in comparison to maybe real life where, you know, they're doing their patient assessment and things like that, so they have a little bit more time exposed to the patient before they actually have to nail down an actual weight?
Thanks for the question there, Trevor. So basically what we chose was around 15 seconds for the time period allotted for that. And we as a research team, we haven't really found anywhere that gave us a time limit per se, but we just felt that 15 seconds would be more than enough for the estimation, because as paramedics, when we walk into a room, we have our first look and the first glance at the patient, and given that first look, you should be able to determine an estimation of how much they weigh in that time.
Okay, I just follow up to that. So with that, you didn't refer to any research prior on timing and the previous you built off of. Did they give the same time limit, or?
So the previous research that we built off, they didn't give a time saying exactly how much time was allotted in between each slide.
Oh, great, thank you.